In this video, we'll step through a rapid critical appraisal of a randomised controlled trial using the Rambo Critical Appraisal Checklist. We will appraise a recent open access randomised controlled trial titled A Telerehabilitation Program in Post-Discharge COVID-19 Patients, conducted by Lee et al. Firstly, we'll orient ourselves to what this study is about. We can do this quickly using the PICO framework. PICO stands for population, that is who the trial relates to. Intervention, that is the intervention being tested in the trial. C is the comparator, that is what the intervention is being compared to. And O stands for outcome, that is the variables that are being measured to determine the impact of the intervention. You can often find all this information in the study abstract, but sometimes you may have to look in the main text of the paper. Using PICO whenever you look at studies can help you decide whether the study is relevant to your patient or problem, whether the intervention is feasible in your setting, and whether it's been compared to something that reflects what happens in your practice. Looking at the outcomes of the study is also helpful for determining whether the study is going to be meaningful to you and your patients. Here's the abstract from Lee et al. You can pause the video at this point to find the PICO elements. From the abstract, we can see that this study includes participants who are hospitalised for COVID-19 who continue to experience dyspnea or shortness of breath. We can also see that the intervention of interest is a 6-week telerehabilitation program that comprises unsupervised home-based exercise delivered via smartphone. The comparison is described as no rehabilitation. The primary outcome of interest is the 6-minute walking distance, and secondary outcomes include squat time, pulmonary function, health-related quality of life, and dyspnea at 6 and 28 weeks. The first item of the Rambo checklist relates to randomisation. For this question, we need to consider the method used to generate the allocation sequence, or the order in which participants were assigned to study groups. The method used should result in the study participants being assigned to groups by chance, or in other words, randomly. You'll find the information to answer this question in the methods section of the paper. Lee et al. State that the allocation sequence was computer-generated by an independent statistician. This is an appropriate method for generating the allocation sequence. Use of a random numbers table or computerized program that generates a random sequence is the ideal method for generating the order of allocation to groups, as these methods, when implemented correctly, assign participants to study groups on the basis of chance alone. We can therefore answer yes to this Rambo checklist item. Lee et al. Used a process called block randomization, which is a way of ensuring that a similar number of participants are allocated to the treatment and control groups. The randomization process is also stratified by hospital. This is done because the study recruits participants from 3 different hospitals, where there may be differences in the characteristics of the patients and or the manner in which they are treated. Stratified randomization is often used in multi-site studies, and in this case results in an even split of people from the different hospitals across the study groups. It's a way of ensuring that any potential confounding factors are evenly distributed between the study groups. We know that an appropriate method was used to generate the order of allocation to study groups, but we must also check whether the allocation order was kept concealed or hidden from the individual enrolling participants in the trial and or from those assigning participants to the study groups until the point they were assigned. This prevents the introduction of bias into the trial through the manipulation by study investigators with regards to who's enrolled or to which study group participants are assigned. In the methods section, Lee et al. State that allocation was concealed by central randomization and only revealed after baseline assessment through call to a study centre. Essentially, a study investigator, in this case a rehabilitation doctor, assessed the characteristics of the participants at the beginning of the trial. Once that was done, another investigator contacted the study centre by phone to find out whether the participant was to receive the intervention or control. This method of central randomization is an appropriate method of allocation concealment, so we would tick yes for this item as well. Finally, we need to consider whether the study groups were similar at the start of the trial. When there are differences in the characteristics of the study groups at baseline, we cannot determine whether any differences between the intervention and control at the end of the trial are due to these differences or to the intervention we're testing. Usually, information about the characteristics of study groups at baseline is presented in a table in the results section. In Lee et al., baseline characteristics of the study groups are presented in Table 1. We can see that important socio-demographic characteristics such as age and sex are compared, and there are details of how sick participants in the study groups were and whether the study groups were similar in terms of outcomes measured before the intervention was administered. We can see that there are some small differences between the groups in terms of age, hypertension and 6-minute walking test, but that overall the characteristics of participants assigned to the intervention and control are reasonably similar, so we can tick yes for this checklist question. To answer this question, we need to consider whether all participants who started the Lee et al. Trial were accounted for at its conclusion. Sometimes participants do not complete a trial, and it is important we know how many this applies to and the reasons why they do not complete. We can find this information by looking in the results section of the study. Lee et al. Provide this information in Figure 1. From this flowchart, we can see the number of participants that completed assessment at the end of the intervention and at follow-up. There was a similar loss to follow-up from the study groups, and greater than 85% of the trial participants overall completed and had their outcomes assessed at the end of the trial. Generally, if more than 15 to 20% of participants are lost from a study, we need to consider the results with caution. We will be even more cautious if there's a large difference in the loss to follow-up between the study groups. The more participants that are lost to follow-up, the more the trial is at risk of bias because participants who leave the study are likely to be different in some way to those that remain. As Lee et al. Clearly display the flow of participants through the trial, we can answer yes to this checklist item. To answer this item on the Rambo checklist, we need to find out whether all participants randomised were analysed and whether they were analysed in the groups to which they were randomised. When this occurs, it's known as an intention to treat analysis, and it preserves the benefits of randomisation. The first requirement of an intention to treat analysis is that participants are analysed in the groups to which they were initially randomised, regardless of whether they cross over to another study group during the trial. Information about how participants were analysed in Lee et al. Can be found in the flowchart in the results section of the paper. Looking at the boxes labelled Allocation and Analysis in the flowchart, it appears that all 59 participants randomised to the intervention group were analysed in that group, and that all 60 of the participants in the control group who met the eligibility criteria and were randomised were analysed in that group. So the first requirement of intention to treat analysis, that participants are analysed in the group to which they were initially randomised, is met in the Lee et al. Trial. The second requirement of an intention to treat analysis is that all participants randomised are analysed. But as we discussed earlier, we know some participants in the Lee et al. Trial did not complete follow-up assessments and therefore would not have outcome data. So how was this handled in Lee et al.? Text in the method section states that main analyses were conducted on an intention to treat basis without imputations. Imputation refers to a process where estimates of outcome data are created and inserted where outcome data are missing. The statement means that though participants were analysed in the group to which they were randomised, outcome data was not imputed where it was missing, and participants with missing outcome data were not included in the main analysis. So strictly speaking, this is not a true intention to treat analysis because not all randomised participants were included in the analysis. However, the approach used by Lee et al. To analyse the study data can be considered acceptable for the following reason. The investigators conducted a pre-specified sensitivity analysis in which they analysed the data with and without imputation of missing values. As the findings of the analysis where estimates of missing data were included and excluded are similar, and the overall proportion of participants lost from the trial was small, the approach to leave participants with missing data out of the analysis is acceptable. We can therefore answer yes to this checklist item. You may also have noticed Lee et al. Conducted a per-protocol analysis. Per protocol analysis are often conducted in randomised trials and refer to the situation where only participants who completed and adhered to the intervention to a certain degree are included in the analysis. As per protocol analysis may lead to spurious conclusions about the effectiveness of an intervention, ITT analysis is the ideal approach to analysing data from an RCT. For this item of the checklist, we need to consider whether the study groups were treated exactly the same apart from the different interventions they received. What we would want to see is that the study groups in the Lee et al. Trial received the same level and quality of care, had the same contact with study investigators, and the same opportunity to undergo other treatments regardless of whether they were receiving the telerehabilitation intervention or not. This information is found in the methods section, but it's often not clearly reported or not reported at all. And this is the case for Lee et al. There's no clear statement that the groups were treated equally aside from the intervention, so we would rate this item as unclear. For the final question of Rambo, we consider the outcomes of the trial and whether blinding was used. When participants involved in the trial are aware of which intervention they're receiving, they may behave differently or respond differently to questionnaires. When clinicians and study personnel are aware of which intervention a participant is receiving, they may alter the care they provide or may subconsciously or intentionally alter their assessment of the study outcomes. When study outcomes are subjective, blinding is critical. We can find this information in the methods section of the trial. In Lee et al., the primary study outcome was a 6-minute walking distance. This test measures the distance a person can walk in 6 minutes with standardized instructions and encouragement being given by the assessor. It could be considered somewhat subjective as the standard methods for performing the test may not be followed. As such, it's important that the study personnel doing the assessment are blind to whether the participant received the intervention or not. The study's secondary outcomes included measures of pulmonary function assessed by spirometry, which is an objective test, and quality of life and symptoms measured by a survey that the participant completes. For these subjective outcomes, which are reported by the participant themselves, blinding to which intervention they receive is important. Adverse events were another outcome of this study. Participant reporting of adverse events was assessed by doctors for severity and relationship to the intervention. It would be important that these doctors were blind to group allocation when making these assessments. Lee et al. Did not blind participants to group allocation. This is because it would not be possible. Participants would know whether they were receiving the intervention or not. So we must interpret the findings for the subjective outcomes of the trial, quality of life and symptoms, which are reported by the participants themselves, with caution. For the primary outcome, the 6-minute walking test, however, Lee et al. Do try to blind the assessors to group allocation by excluding them at the time participants were allocated to the intervention and control, and by asking participants and therapists not to disclose which intervention they received. The doctors assessing the adverse events were also blind to group allocation. So overall, we could answer this question as yes. For the primary outcome and adverse events outcome, assessors were likely blind to allocation, but we should keep in mind that there could be concern for bias with the participant-reported measures of quality of life and symptoms. We've now completed our appraisal of the Lee et al. Trial. By using the Rambo checklist, we've focused our attention on the key aspects of the trial methods that could lead to the introduction of bias. As this example shows, we can do this assessment quickly to give an overall picture of the validity and trustworthiness of the trial. In this trial, we can be confident that the process of randomly assigning participants to study groups and measurement and blinding of study outcomes was done well. We do need to keep in mind that for the subjective outcomes, quality of life and symptoms, the participants reporting these outcomes were not blind to the intervention. It is difficult to tell whether this would lead to an overestimation or an underestimation of the effects of the intervention, but we should interpret these findings with caution. We've judged that the participants were accounted for and analysed appropriately, though we're unsure if the study groups were treated equally except for the interventions received. As most of the items of the checklist are answered yes, and only one was unclear, we can be reasonably confident that the risk of bias in the study is low, and that the findings of the trial can be trusted. We hope you've enjoyed this video. If you have any comments or suggestions for improvement, please use the contact information provided here. This video was developed by the Institute for Evidence-Based Healthcare at Bond University with support from the Council for Allied Health Professions Research Northern Ireland Hub.